What is the journey of randomized controlled trials in heart failure? Friends, somewhere in 70s and 80s, I remember in olden days, heart failure was a very ominous diagnosis. We just could not do anything. Digoxin, diuretics, and at best nitrates were the dominant line of therapy, and we used to give inotropic infusions in patients who used to worsen, which nowadays we do not know. We do not do. Uh, the heart failure, successful heart failure trials started coming in from 86 when valsartan heart failure trial had come, and then subsequently there was flurry of trials on ACE inhibitors, ARBs, and somewhere in 1990s beta blocker related heart failure trials like Merit heart failure, CIBIS, etc. came. ARB's Rails trials came, Copernicus trial came, and lastly, then we had a number of trials where device therapies were used, like implantable cardioverter defibrillator in patients who were predisposed to sudden cardiac death, cardiac resynchronization therapy in patients who had dyssynchrony in their left ventricular contraction. But the icing on the cake, the big step forward was the ARNI paradigm heart failure trial, which was published in 2014. And then subsequently there are flurry of trials of different aspects of heart failure being aggressively tackled by ARNI. Very rapidly it got approved by various drug controller authorities in America, in India, etc. And it became a very big step in the management of heart failure. The paradigm heart failure design was such that it was a randomized double-blind placebo-controlled trial. It was preceded by a run-in period, 2 weeks of therapy with enalapril up to 10 milligram twice a day, followed by 2 weeks of therapy with ARNI, started with 100 milligram twice a day for 2 weeks and 200 milligram twice a day for another 2 weeks. Then the patients were randomized either to receive enalapril 10 BD or ARNI 200 milligram twice BD as per the patient toleration, and the double blind phase was continued for another few years, almost 3 years. The inclusion criteria were patients with heart failure with reduced ejection fraction on more than 4 weeks of stable treatment on ACE or an ARB and a beta blocker. NT-proBNP had to be more than 600 or more than 400 with recent hospitalization for heart failure within last 12 months, and aldosterone antagonists were considered as and when required. Exclusion criteria were angioedema, EGFR less than 30, symptomatic hypotension less than 100 systolic, requirement for treatment for ACE or ARB mandatory for some other reasons, potassium more than 5.2, and recurrent acute decompensated heart failure or history of severe pulmonary disease were few of the exclusion criteria. This was largest mortality morbidity trial in patients with HFrEF, and majority of geographical regions were included in this, and most racially diverse heart failure trial was there. So this is a trial which finds its implementation across all regions, across all races, because they were all included. The major benefit was on top of guideline directed medical therapy available at that time, standard of care available at that time. Cardiovascular death came down by 20%, heart failure hospitalization came down by 20%, all cause mortality came down by 16%, heart failure death came down by 21%, and sudden death also came down by 20%. So it was not just the prevention of pump failure related death, but even arrhythmic deaths came down. Just to keep the things in perspective, the medical therapy for stage C heart failure with reduced ejection fraction, ACE inhibitor or ARB have a relative risk reduction of 17%, giving rise to number needed to treat for mortality reduction over 3 years is just 26. You treat 26 patients for 3 years, you reduce 1 death. And relative risk reduction in heart failure hospitalization was 31%. The similar data for beta blocker, mortality reduction 34%, number needed to treat over 3 years is just 9 to prevent 1 death, and heart failure hospitalization reduction 41%. Aldosterone antagonist gave rise to a relative risk reduction in mortality of 31%. A very small number of patients you need to treat to prevent 1 death, that is just NNT was just 6, and heart failure hospitalization came down by 35%. Hydrogen nitrates cause relative risk reduction in mortality of 43%. Number needed to treat is just 7, and reduction in heart failure hospitalization 33%. In this perspective, if you see, the ARNI gives rise to, on top of all these benefits when they are on all these therapies, it gives rise to 20% reduction in mortality. Number needed to treat for reducing 1 death over 3 years is 32, and heart failure hospitalization came down by 21%. Though the figure looks little smaller, friends, it is on top of the existing benefits we just enumerated. There is a significant improvement in quality of life reflected in improvement in NYHA class. Within 30 days of treatment, there was a significant improvement in NYHA class. Almost 34% of patients experienced at least 1 stage improvement in NYHA class. There were a large number of patients who before sacubitril valsartan were in stage 2, stage 3 and stage 4 became either asymptomatic or just mildly symptomatic, that is NYHA class 1. Subgroup analysis of this trial. Does this trial apply to all subgroups of various clinical criteria? Yes. Whether the patient is younger or older, below or above 75 years of age, benefits were similar. Ejection fraction, whether it was less than 35 or more than 35, benefits were similar. eGFR, whether it was below 60 or above 60, benefits were similar. Patients were hypotensive or not hypotensive, systolic BP less than 120 versus more than 120, benefits were similar. And NT-proBNP, whether they were very high or not very high, benefits were similar. So, this is a beautiful class action which is seen across all the spectra of the patients. And if you see the Asian patients, subgroup analysis of Asian patients, all the parameters like primary composite outcome, cardiovascular death, heart failure hospitalization, all-cause death was similarly beneficial in Asian patients versus non-Asian patients, and among the Asian patients also South Asian, East Asian, Southeast Asia all had a comparable benefit, so they are applicable to our patients too.